So I'd like to thank the department and the academy for allowing me to do rounds today. And the talk today is something that a lot of guys have been asking about, and it's something that we've looked at our center, and that's sepsis occurring after biopsy. And this presentation takes into input that we've had from radiology and then partially from infection control, because it's a work in progress. And, you know, when we think about this topic, it's like, why are we talking about it, and why are we talking about it now? And I think there's a general perception amongst the urologists that there is an increase in the number of patients who are presenting with post-biopsy sepsis. And then we're finding that these patients, or there's a concern that there's an increase in ciprofloxacin-resistance, and that's our standard antibiotic that we're giving these patients before biopsy. And there's also a trend that there's some community urologists who are actually going and giving intravenous antibiotics in uncomplicated patients before biopsy because of patients who are profoundly septic presenting to their hospital afterwards. And so we have to go back and look at the data and see whether or not that's really a justifiable change in practice. And so as our learning objectives from today, we're going to start out by reviewing through the patterns of antibiotic resistance that are relevant to this discussion. We're going to discuss nosocomial infections and the current state with antibiotic prophylaxis. What is the role of pre-biopsy enema? And then going over a quality assurance audit that we're still working on at Vancouver Hospital. And then the most important thing is obviously to try and get doctors to agree on common protocols. Yeah, that's exactly it. That's McLaughlin and Wright fighting over the main. That's Fenster and myself. So. Yeah, exactly. So when we start this discussion, let's talk about antibiotics and the prostate. So for antibiotics to get into the prostate, it's a passive process, and that they have to diffuse in and then concentrate in the prostate. And they have to have a high lipid solubility with minimal binding to serum proteins. And the advantage of things like quinolones is that they don't ionize in biologic fluids, and so they can easily cross through into the prostate. We know from animal models and then the work in chronic prostatitis, our friend Curtis Nickel has shown that there's improved eradication with quinolones. And so quinolones are really the best antibiotic class for treatment of prostatitis. Well, when you're talking about bugs and antibiotics, you have to think, okay, what bacteria are we going to need to cover? And what are the potential intrinsic resistances or inherent resistances that some of these bacteria have to the antibiotics? And trimethoprim, the old, sulfa that many docs will use, well, we know Enterococcus and Pseudomonas are resistant to it. Nitrofurantoin is bacteriostatic, and it has poor tissue penetration and resistance intrinsically to by Proteus and Pseudomonas. Cephalosporins as a class don't cover Enterococcus or Pseudomonas. And then the fluoroquinolones provide really not great coverage for anaerobic bacteria or streptococci, and then our standby gentamicin has really no significant anaerobic coverage. And so what do we need for an antibiotic to treat an infection of a tissue infection in urology or a bacteremia? Well, it has to be active against the potential bugs that are causing the infection. Bactericidal rather than bacteriostatic, high serum and tissue levels, minimal toxicity, and potentially a long half-life. So that you can use a shorter dosing interval, so they don't have multiple doses per day. And the quinolones are great because they're bactericidal and they covered most of the gram-negatives. They've got great, excellent oral absorption. And there's bioequivalency between intravenous and oral formulations. And you get rapid and high peak serum levels, high tissue levels. But we have a problem in that there is an increase in the resistance to the quinolones. Most of this is felt to be due to selection of a drug-resistant clone, a chromosomal alteration that's occurring. And that's leading to mutations in the DNA gyrase, binding site, and other resistance patterns that are reducing the ability of the drug to concentrate in the bacteria. The problem is that with many of these, the newly resistant bacteria to the quinolones, there is a plasmid-mediated resistance that is conferring a quinolone resistance gene that's going to be a big problem for us in the future. So where we are right now is going to get a lot worse over time. And what is the resistance that's occurring worldwide? Well, there's up to a 30% resistance to E. coli in a place like Spain. And traditionally, we thought that we had a very low incidence in outpatient E. coli samples of resistance, 3.6% in 2004. But we know from Europe that there is an extended spectrum beta-lactamase producing strain of E. coli that is highly resistant to the quinolones. And this is going to be a bug that's going to be coming here eventually. And so what are the risk factors that someone could get colonized with a quinolone-resistant strain? Well, increasing age, and whether or not that's just due to multiple changes in immunosuppression that occur with age, or if it's just more exposure, people that have traveled to developing countries or countries in which there's a high incidence of resistance to the quinolone, such as Spain, and then prior quinolone use. Well, we think, okay, this problem is primarily over there and it's not here. So we can take an isolationist approach and say that, you know, it's not a problem here. But these are looking at this is from MDS Metro, and we're looking at the local lab here, local lab in Burnaby, in which, if you look at the E. coli on the top line, you've got 18% of the E. coli are resistant to ciprofloxacin. And then if you go over further to the right with the trimethoprim sulfamethoxazole, it's, you know, there's 22% resistance. And so it is increasing, and this is just going to change over time. And we decided to really look at the outpatient labs for the resistance rather than looking at VGH, because within VGH itself, you're going to probably get a higher incidence of Cipro resistant because of a major teaching hospital. And for example, on transplant wards, it's been described in the States that the Cipro resistance amongst the E. coli is much, much higher. And so we, you know, in terms of the patient population that we have that we're sending for biopsy, I think this is more relevant. And then you can see that we have, that they do indicate that there are certain bacteria in which they know they're inherently resistant. And so they don't bother doing the sensitivity. Yes, Ken? Not that I could get from MDS, but what's happening is that in Europe, the patients who have resistance to the cephalosporins and amoxicillin, that's tending to that E. coli is getting selected for quinolone resistance. And then we've talked about that extended spectrum beta-lactamase E. coli, which is going to be resistant to your cephalosporins, your aminopenicillins, and 56% of them are resistant to quinolones. Dr. Masterson. I think it's just based on the well, we don't have our ID doc here, but I think it's just based on the MIC. I'm not sure. Yeah. I think it's a standard testing. I can't answer that, John. So you would think, okay, what's happening in Vancouver? Well, let's see what's happening in Fortress, Victoria. Same thing, in that they have 79% sensitivity to E. coli, 80% sensitivity to trimethoprim sulfamethoxazole. And so over time, this is something we're going to need to watch as we go forward in terms of if the Cipro resistance is increasing, we really do have to look at what we're doing for our antibiotic prophylaxis before biopsy. Yes, Dr. McLaughlin. Yeah. Well, that's the thing. I think that for uncomplicated UTIs, the nitrofurantoin is clearly underutilized. I think for complicated infections, I don't think there's a role for nitrofurantoin, and that includes post-biopsy sepsis and bacteremia because it's bacteriostatic, and you don't get those high tissue levels. And so, unfortunately, when the docs are perceiving that there's an increase in the number of patients presenting with E. coli, we tend to sort of want to it's a bit of a blame game, and that people want to move the focus and say, okay, something's happening in radiology that is the contaminated equipment, et cetera, rather than just sort of going back and looking at the data, looking at the trends over time. And so the question that we've asked is, are any of these post-TRUS and biopsy infections nosocomial? And so when you think, okay, what could be a nosocomial source? Well, you're looking for the unusual organism, and this would be the patient is presenting after biopsy with a multi-drug resistant organism, or Pseudomonas, which can be contaminant of rinsing with tap water with inadequate rinsing with alcohol of the equipment afterwards. But then for everything else, it's an assumption. Maybe it's a weird organism, MRSA, but we've got a huge problem in the pipeline of community-acquired MRSA that's coming. And it's a big problem in the third world. It's going to be a problem here. Think of coag-negative staph or weird enterobacter bacteriaceae, such as Acinetobacter, Enterobacter providencia, or Serratia. Proteus, for example, about 25% of the general population is colonized in the GI tract with Proteus. So I don't think we can say that if we had an outbreak of Proteus, that unless it was a massive outbreak, that it's related to contamination at the hospital. And so when we went through this, as part of the process over the last couple of years, radiology has really been proactive in terms of looking at what they're doing with the patients that are undergoing biopsy. And one of the big problems is, and this happened in Toronto, is that people were not doing an appropriate clean of the biopsy guide. That's a reusable biopsy guide between patients. And so a new biopsy guide, which is properly disinfected between patients, is used for each of our biopsies. And this was a problem that occurred in Toronto and was in sort of the media and the medical press. And then obviously double condom cover over the probe, because the failure rate of just a single condom is anywhere from 1% up to 80% when people have looked at that. And so that's another thing that radiology has done to try to reduce that chance of a nosocomial source. And then when we're going through this, we're thinking, okay, we're having people are saying that there's an increase in infections occurring, and maybe it's occurring in radiology, or maybe it's just what's happening out in the community with the Cipro resistance. And this is just data that we have from Vancouver Hospital, and unfortunately, infection control could not give me the 5-year trend yet. But if you can see at this hospital, these are patients who are, these are hospital bacteremic events, and what you can see is that for most of the organisms, there's really been either a static picture or an actual reduction, depending on the organism. But for E. coli, it has increased in the last year, and so this is something that infection control will be looking at. And then the next thing is that, okay, are nosocomial infections increasing at VGH? Well, is there an increase in a urine source? And that is something that has been seen in the last year. You have to also, though, think, okay, we all know from our practices that we've got a sicker patient that's coming to the tertiary quaternary referral centers now. And so it would be nice to look and see what's happening here, what's happening at Burnaby or at Richmond or at Lionsgate, in terms of they're seeing similar patterns. And that's something that the infection control at a health authority level will have to work on. And then what about bacteremias from outpatient facilities? In that there has been an increase in radiology from 13 to 21 events, but when we did our audit, there was only 7 post-TRUS and biopsy infections. So you've got basically 14 cases that are occurring in radiology, people admitted with bacteremia. Erkley. These are patients that are coming back to VGH, and that's the problem, is that we're having patients who are having a biopsy or a procedure done at VGH, and then they live in the catchment area of St. Paul's, and they're going into St. Paul's or they're going into Richmond. And so we really have a significant underreporting of what's going on. Because you and I have discussed this, that, you guys are taking care of a lot of patients that have had VGH-specific procedures, and then they're presenting at St. Paul's afterwards. That's pretty much your take? Okay. Well, once we've talked about, potential nosocomial, we're thinking, okay, how can we prevent these? How are these patients presenting? And so the usual presentation for patients with post-biopsy sepsis is within the first 3 days, but from the older literature, patients sometimes took up to a week to present. From the early 80s, people were thinking, well, a gram-negatives, enterococcus was a factor, but for most modern series where they've looked at patients presenting, it's always aerobic gram-negatives for the most part. Common thread is that the urine cultures are often negative, and in many studies, the blood cultures may only be positive in up to 2/3 of the patients who are profoundly septic. And the concern, as I said before earlier on, is that I think a lot of the docs think that those who have institutional memory of how been in practice for a long time, they think, okay, the patient may seem sicker than they did 10 years ago. I can't say that because I haven't been in practice long enough. Well, let's look at the incidence. And these are studies in which they have looked at both patients who have had prophylaxis and those who have not. And as a general trend, the infection rate in those who've had, and this is patients primarily who have bacteriuria, UTI afterwards, this with septic patients being a significant minority of that patient population, I think it's less than 2% as a general trend, versus up to 10% if you look at historical series or cohort series in which they looked at the results of patients who had no antibiotics and then they switched to antibiotics. And so for most studies in which they have compared no antibiotic to giving antibiotics, substantial reduction with giving antibiotic. Well, what are the risk factors? And these are a bit nebulous, and not well outlined and contradictory in a lot of the studies. Pre-biopsy bacteriuria is felt to be one. Patients who've had recurrent bacterial prostatitis. And so Dr. Buckley and I have discussed the patient who gets sent in for a TRUS and biopsy, and they say, well, I've had prostatitis before. And I think from the radiologist's point of view, there's an uneasiness that perhaps that patient's going to be at higher risk, but we're still treating them the same. They're still getting the same antibiotic prophylaxis. Well, anybody with the immunosuppression, the diabetics, other immunosuppression, steroid use. And then we have to worry, okay, patients who've had multiple courses of antibiotics. And we all have patients that, they may not report that they've been put on ciprofloxacin for an upper respiratory tract infection within the year. And that may have resulted in a resistant organism in their GI tract that's going to lead to problems with the biopsy. And then question is whether patients who are coming in who are carrying a high residual are at higher risk. Variety of antibiotics that have been done over time. And there's just been the trend that, from single doses of antibiotics either before or after, in which there's probably no difference, to more commonly patients getting a 3-dose regime or a 3-day regime. And then there's going to be some studies where they're going to be looking at a longer duration. And then from, the 80s and early 90s, we have a historical control, people using the trimethoprim sulfamethoxazole. Well, what is the optimal duration for the antibiotics? When we look at some of these studies, and I've outlined those that are in RCT, up to 25% in the Aaron study had an infection without any antibiotic. But then if you look at the numbers, looking through each of these studies, I don't think that there is a real advantage of going beyond 3 days. I think that when I was looking through the literature, I couldn't find any good study where they compared a 3-day to a 7-day. And so our current practice right now for most of our docs at VGH is that we give usually for 3 days starting the day before the biopsy. And we've been doing that since probably, when did you guys switch over to single dose, Jean? From single dose? I think it's longer than that. I think it was probably 2000, 2001, because most of the patients we audited were 3 days. So, well, what is an argument? People are now sending the people, they think, okay, I'm going to prevent the infection by putting the patients on a longer dose of antibiotic. But you have to take into account that that the incidence of urosepsis afterwards is very low. And so it's going to be very hard to see a difference with a 3-day versus a 7-day. And the sepsis is due to resistant organisms. It's not an inadequate duration of antibiotic coverage, and that we are potentially contributing to overuse of quinolones, resulting in more resistance. But the devil's argument is to say, well, a single dose of Cipro, say, $3 to $5 versus $1,500 for an acute inpatient day for treatment of urosepsis at VGH or other hospitals. And so, sorry about that. And so one of the things that we've done in the last year is that because the data on the benefit of an enema is very limited, we've looked at our results for patients who did not get an enema, and now almost all the patients who are presenting for biopsy at our center are having an enema beforehand. And we're just going to see whether or not there's a reduction in patients presenting with infection afterwards. And when the first study here by Carey and Corman, this is a study in which they're looking at, this was not a RCT, but they looked at various staff persons' preference. Some used an enema beforehand, pretty standard doses of standard duration and choice of antibiotic beforehand. And they looked between those biopsies done by staff that did give an enema versus those that did not. And there wasn't really a substantial difference. The Lindert study is an interesting study in that this is 50 patients. It was an RCT in which they did not give any antibiotics beforehand, and then half of the patients got an enema, half didn't, and about 15 minutes after they had their biopsy, they got blood cultures drawn. And you can see that there's a transient bacteremia is substantially higher in those who did not get an enema. The issue is that of these, there was 8 patients in total that had a transient bacteremia. Only one of them was symptomatic, and that patient cleared immediately. And so it's a bit hard to draw conclusions from that to say that you really need that there's going to be a clinical benefit with a reduction in post-biopsy sepsis by giving an enema. And then we have the historical control of Guy Valencien's study very early in the 91, where they thought that perhaps enemas were causing irritation of the rectal mucosa. And that was a big reason why a lot of docs went away from giving enemas before the biopsies. Well, we talked earlier about a trend that some docs are so worried about their patients getting profoundly septic from biopsy, even though it's a minority of the patients, that they have switched to giving them intravenous antibiotics beforehand. So I looked through the studies in which they have actually given intravenous antibiotics, and variety of regimes in which the first study is comparing piperacillin against oral ciprofloxacin, and not a substantial difference, but it may be that the study, you're always worried with these studies, is that they're underpowered. The Brewster study looked at comparison between 2 intravenous antibiotics, in which cefuroxime, which is a second-generation cephalosporin, was better than the piperacillin. And then you have a study by Otruk et al., which is based from the American University in Beirut, in which they looked at, it was not an RCT, but they looked at the potential benefit of adding gentamicin to a 2-dose regime of ciprofloxacin, and they didn't see a substantial benefit. And then most importantly, we have a study by Shivd in 2002, in which they compared that older antibiotic choice, the trimethoprim sulfamethoxazole, to a single dose of gentamicin, in which they said that because of likely impaired penetration of gentamicin into the non-inflamed prostate, there is still an advantage of using the Septra. Well, what patients tend to get intravenous antibiotics prior to a TRUS and biopsy? Well, it's anybody who has a mechanical heart valve or they've got a recent prosthetic, like less than 2 years. But, what about those patients that we all have who've had a background history of acute bacterial prostatitis, the diabetic, the patient who's immunosuppressed, the person who has had, who comes with an indwelling catheter, and you've got an abnormal DRE and you're sending them for biopsy? What about that patient who reports that, oh yeah, I had a biopsy 3 years ago and I presented to UBC and was in hospital for a week with sepsis? We still have these people presenting to the radiologist, and they're taking the history at the time of the biopsy, and it's not outlined anywhere else. And they're like, well, should I give them some IV antibiotics right now before the biopsy? And then what about the patients who have multiple courses of antibiotics? And specifically is that you're dealing with an older population in which it's a very easy, for an upper respiratory infection, that the fluoroquinolones are used as first-line therapy for a lot of presumed bacterial etiologies of an upper respiratory tract infection, when most of those patients are in fact viral. So we've got a few specific questions that Jean and I wanted to look at, and then no one's gonna in a modern era is gonna want to have a biopsy without local put in. But there's some centers in which they put lidocaine gel into the rectum, and they don't do a periprostatic block. And there's been a number of studies in which private practice groups like CBER in Pennsylvania, where they looked at their historical trend of patients who didn't have a periprostatic block, and then in a publication, say in 97, and then in 2007, they are doing a periprostatic block, and they didn't notice a difference in terms of an increase in sepsis in those who had a block. Well, we went and found this study by Obeck et al., in which it was an RCT, and they randomized the patients to local. They used intrarectal lidocaine and then local infiltration with a block, and versus no anesthetic. All the patients standardized to having an enema versus septor, and they found that those obviously who did not have in terms of specifically focusing on table 3, looking at the infectious complications, there was a trend towards, there was, obviously it's hard to see if there's a true difference, but in terms of serious clinical infections, there was actually 2 that were in those who had local anesthetic put in, and that there was an increase in bacteriuria that was statistically significant in those who received local anesthetic block. And there was a trend towards higher fever in those who had a block. But the reality is that we're going to continue to do blocks, but we have to think, okay, is this something that we have to watch over time, and could it be a contributing factor to why we're seeing more sepsis now than we did, say in the late 80s or late 80s, 90s. Next question is that what about that patient who you're sending for rebiopsy? Are those patients at higher risk for complication? And this is a study that was it was a European screening study for prostate cancer, and these are patients who had a negative initial biopsy, and then per protocol they underwent a repeat biopsy at 6 weeks. And when they analyzed the results, they did not notice an increase in infectious complications in those who had a rebiopsy. And so we're going to go on to our quality assurance audit that we've started at VGH, and this is just a work in evolution. And because we're looking at the results from other centers, and then we want to see, okay, what's happening in our own population, what's relevant to us. Case finding is very difficult. As I said, is that we looked at all of the patients who had biopsies between 2001 and 2006 between VGH and UBC. We had to because it's an outpatient procedure. When you go to QUIST and you try to, which is our organization for quality improvement, to try to track down these cases, they can't track down the cases. We had to cross-reference the names of the patients who had a biopsy done as an outpatient procedure with those who had an inpatient admission within 30 days of the biopsy. And that was only relevant for Vancouver VGH UBC. And the problem is we could only find 26 patients. And Erkley Leone, who's our site head at Providence, he's always dealing with patients that from VGH urologists who, the patient presents because they're so sick to St. Paul's because that's with their catchment area, or the Richmond guys are dealing with, or Lionsgate, or Burnaby. And so we have I think we have the potential for significant underreporting of the problem. But, in terms of the numbers, it's a very rare event that we can find. Even if we are underreporting it, it's still a rare event. Our standard, Dr. McLaughlin.
Why couldn't you think of the same name for the hospital?
We would have. Yeah, we've actually looked into that, and there's another way that we can track them through the Ministry of Health, and that's something that we're going to do through infection control. Yeah. And so, absolutely. Yeah, and there's actually when we reviewed it with medical microbiology, they said that there's a process you can go through with the Ministry of Health to get that. That's actually easier, and it's just through to the patient's PHN. During this time, none of the patients had an enema. That was the standard because radiology had previously reviewed through the literature and had determined with urology that there's really no clinical benefit to doing an enema beforehand. And the standard was that the patients, for the overwhelming majority of the patients, had 3 days of Cipro for prophylaxis. But oftentimes Dr. Buckley will have patients presenting who have a 7-day course of antibiotic has been prescribed by the referring urologist, and so but for the most part, it's 3 days. Well, when we looked at our results, most of these patients are presenting within the first couple of days, and of the 26 patients, only 17 had a positive blood culture, and overwhelmingly these were with E. coli, and so we're not seeing really unusual bugs that would suggest that it is a nosocomial source. Of the 17 that had positive blood culture, 16 were resistant to ciprofloxacin. So it's a cipro-resistant phenomenon that we're seeing. Now, the next question is, the doc wants to know, okay, the patient is presenting here, what antibiotic do we start them on? And we found that of the 13 of the 17, they were sensitive to gentamicin. And, we all have, if you've been in practice long enough, you've got patients who have developed ototoxicity or a nephrotoxicity from a gentamicin or aminoglycoside, but the data is the data, and gentamicin is a good first, your first choice for antibiotic. Now, the next thing is that, okay, of these patients presenting with sepsis, if I put them on another oral agent, such as trimethoprim, sulfamethoxazole, am I going to cover? Well, only 7 out of the 17 were sensitive to that, and so we've got less than 50% of those patients would have benefited from that, from a double coverage. This is it's a little. We'll have to reorganize this, but if we look at the positive blood cultures, one of the problems we found, like on the left, you have the organisms of the 17. How many of them are sensitive? So we got, for gentamicin, we got 13 that were sensitive, 4 that were resistant of the 17 that had positive blood cultures. The problem is that when the cultures were done, they weren't doing sort of a panel of antibiotics, and oftentimes, for now, the residents nowadays will actually go and call down to the lab and get them to do more, a wider spectrum of antibiotics. Because one of the things is we have an incomplete picture of our coverage of whether or not the 2nd and 3rd generation cephalosporins are going to be a good option for us for treatment of these patients as first-line therapy. Well, urine cultures are less than, it was only 13, so 50% of them had a positive urine culture, again for E. coli, resistant in all of the positive urine cultures, and organs were sensitive to nitrofurantoin, but that's not going to help because that's not an appropriate antibiotic to prevent this type of infection. Now, this is actually a great study that was Jack Baniel in Israel had done, in that they looked and they had their bacteriology, microbiology group did wider spectrum sensitivities for all their organisms, and they looked at their 23 patients that had presented with urosepsis after biopsy. And what you can see is they've broke it down into 2 major groups, because 100% of the patients got antibiotic prophylaxis, but only about 70% of them got a fluoroquinolone. And so that's why they've broken it down into, you've got percent of all cultured bacteria up on the left side of table 2, and then on the right side you have the percentage of patients who received fluoroquinolone. And what you can see is that the 1st generation cephalosporins are really not a good option at their center. Okay, and this is Israel, it's not Vancouver. The second and third generation cephalosporins, even in those who receive ciprofloxacin, have done well. But let's look at our friend gentamicin, in that you've got, of the total group, a quarter of them are resistant to gentamicin, and that's a bit worrisome. Amikacin, however, 100%, but how often do we use that here in Vancouver? I've never used it. And you can see, look at how the resistance of the patients to, like, sensitivity over on, of those who received the fluoroquinolone, 91% were resistant to the Cipro that presented with urosepsis afterwards. And then in terms of our backup plan of double coverage of using Cipro and Septra together, you've got, less than a third of them that are sensitive. And so double coverage is probably not the answer for them. And whether or not it's going to be the answer for us over time is, I think, it's debatable. So out of our initial work on this, what are our recommendations? Well, this is a rare event. And so I think it's important not to overreact. We want to look at trends over time. The average number of patients presenting is 6 to 7. There hasn't been a dramatic, over the last 5 years, there's not been a dramatic increase in the number of cases presenting of biopsies done at VGH presenting back to VGH UBC. But as I said, we've got an incomplete picture because of patients going to, the emergency closest to them. Tends to present quite early, and that it's a Cipro-resistant event that we're seeing. So this antibiotic resistance suggests that we should reevaluate our antibiotic. Whether or not this combination of using Septra and Cipro together I don't think it's evidence-based to do that, but I think it's something that we have to think about over time. But I don't think that the sensitivities I think are not high enough to really completely justify that. And at least at VGH, if the patient is presenting with sepsis, gentamicin as the first-line therapy is quite a reasonable antibiotic to start with, and it's justifiable even if the patient develops a complication of the aminoglycoside based on the data that we have. And so what else have we done? Well, we're spending more time. We should be looking to make sure that the patient does not have a risk factor that's untreated. The patient has got preoperative bacteria or pre-biopsy bacteria that needs to be treated. We have reintroduced biopsy or enema before biopsy, and then we're going to look at our cohorts over time and see whether or not there is a reduction. And we have to go back to our old data and actually get a better idea of how many of these patients really are presenting. And as Jean and Lindsay McCann have indicated, there are still patients that we'll be able to track who are still not getting an enema beforehand. And so we could go and track those patients over time, but I don't think we're ever going to have high enough numbers to be able to see a meaningful difference. We have revised our warning in that on the warning that goes to the patients after their biopsy that the radiology department gives to the patient, we warn them more stringently about presenting immediately after biopsy to the emergency. And we've sent out warnings to the emergency docs to let them know that if the patient's coming back, don't put them on more IV Cipro. We still catch emerge docs doing that, and then you have to phone them and have a bit of a come to Jesus meeting to tell them that this isn't appropriate. It's not going to help the patient. You have to choose a different antibiotic. And that's the end.